Okay. Right. Good morning and welcome to the inaugural meeting of the Derby and Derbyshire Integrated Care Board. My name is John MacDonald. I'm the chair of the Integrated Care Board, and as this is the first meeting, I thought we'd just go around and introduce ourselves for members of the public so they know who we are. So I'm just going to call off the names of people on the list I've got here, so that we have some sort of order in there. So Tracy first.
Morning, my name is Tracy Allen. I'm the Chief Exec of Derbyshire Community Health Services Foundation Trust, and I am a partner member on the ICB.
Thank you. Chris?
Good morning, colleagues. Chris Clayton, Chief Exec of the ICB.
Julian?
Hi, good morning. Julian Corner, non-exec member of the Integrated Care Board with responsibility for strategic commissioning, population health and public engagement.
Dean?
Morning, Dean Wallace, Director of Public Health for Derbyshire, partner member of the board.
Buck?
Good morning, everyone. Buck Dada, I'm a GP and I'm also the non-executive member for Quality and Performance and also the Vice Chair of the board.
Helen Dillison?
Hello, good morning, everybody. I'm Helen Dillistone. I'm the Executive Director of Corporate Affairs for the Integrated Care Board.
Keith?
Good morning, everybody. My name is Keith Griffiths. I'm Chief Finance Officer for the ICB. Thank you.
Zara?
Good morning, I'm Zara Jones, Exec Director of Strategy and Planning for the ICB.
Ifti?
Morning, everybody. I'm Ifti Majid. I'm a partner member from the mental health sector and Chief Executive of Derbyshire Healthcare.
Andrew?
Good morning, Andrew Mott. I'm a GP in Amber Valley and the Primary Medical Services partner member for the board.
Suzanne?
Good morning, Suzanne Pickering, Head of Governance.
Amanda?
Good morning, Amanda Rawlings, Chief People Officer for the ICB and for University Hospitals of Derby and Burton.
Amanda? Sorry, Bridget, rather. It's only twice Amanda, sorry. Bridget?
Good morning, everybody. I'm Bridget Stacey. I'm Chief Nursing Officer and Deputy Chief Exec for the ICB.
Sue?
Good morning, I'm Sue Sunderland. I'm non-exec member for Audit and Governance.
Chris?
Good morning, everybody. I'm Chris Weiner. I'm Chief Medical Officer for the Integrated Care Board.
And Richard?
Good morning, everybody. My name's Richard Wright, and I'm a non-exec member of the Integrated Care Board and chair of the Finance, Estates and Digital Committee.
And I think that's everybody. Are there any other members of the board who I missed out? Okay, good, thank you. And just welcome Darren, who's providing.
Sorry, John, you did miss me. My name's Pervez Sadiq, and I'm the Service Director for Adult Social Care, and I'm deputising for Andy Smith.
Oh, sorry, Sadiq, I do apologise.
Who is the local authority rep on the ICB. Thank you.
Thank you very much. I do apologise for that. I must have missed you out. Apologies, Sadiq. Okay, so the only apology we received, well, with Andy, obviously, and Dr. Abu Bhatia, who's the chair of the advisory group. He's also given his apologies. Other than that, I think we're all here. Any declarations of interest? First of all, on the register of interest, are there any corrections? I've got one correction for myself, and I'm no longer on the Nottinghamshire ICS board, so I should have corrected that a while ago. Apologies for that. We've, I think, had some declarations of interest for the items 4 and 5. Just to note there, with Chris having a declaration of interest there, but other than that, I don't think we've got any problems. So we've introduced members of the board. So if I might just make a few comments on the board itself. First of all, this is the inaugural meeting, and although we've been working for a number of years now in partnership and collaboration, I think done some really good work across Derbyshire. The Health Act of 2022 actually establishes the ICB on a statutory footing, and that does give us some additional abilities in terms of working together. The Act itself spells out the statutory responsibilities of the ICB, and indeed some of the papers later on in this meeting give further details of that. I've actually, in my mind, have sort of brought those together in 3 missions. The first is to plan and secure the delivery and deliver cost-effective, high-quality integrated care across the health and care system. The second is to enable and empower partnership working and collaboration. And the third is to be a valued and effective partner in improving the health of the population, reducing inequalities, addressing the wider details. Care to work differently to how we've worked previously. The nature of partnerships means that we cannot be a hierarchical organisation, that we must be much more rooted in our communities, that we've got to trust each other's roles and to make sure that we're supporting each other across the health and care system. And we'll be setting out some of those in terms of how we work. So this is a real privilege and of huge importance to improving the health of the population. And I'm now going to ask Chris if he'd just talk to us a little bit more about some of the key ways in which we're trying to move this forward. So, Chris.
Thank you, Chair, and again, good morning, colleagues. There was, from my end, there was a little bit of a technical challenge there with, I think, your introduction, John. So hopefully I will reaffirm what you were just describing. I will, please, if Suzanne could alert me if when I share my screen, if that just causes any challenges with sound quality or anything from a bandwidth perspective, I'd be grateful. Okay. I'll just keep an eye out for that. If you can just give me 1 second, colleagues, I shall just load a few short slides for you and just talk you through just as a framework for the conversation. And they should be coming to you now. And hopefully you've got a slide in front of you just with the introductory thoughts title there. Just before I launch into this, really, I'd just like to say my final thank you to the previous holders of the infrastructure for the NHS, with CCG's ending and being absolved yesterday, and I'm sure all colleagues would like to just set out our formal thanks to Avi as chair and the colleagues of the previous governing body, who I think we're all assured did the best that they could with the job they were asked to do. I suppose the purpose of this very, very brief presentation is to set out the new ask against familiar challenges, I think it's fair to say, and just from my perspective, just put a marker in the sand for us to come back to about some of the concepts and thoughts we might want to develop as a board. I suppose I'll start, if I may, by just setting out what I believe to be the strategic challenge that the Integrated Care Board and the broader partnership through the Integrated Care System, the Integrated Care Partnership, inherits. And colleagues will have heard me say this before, but there are 3 things in my mind that we need to address. We've got what I call a health gap. So as we know, there are challenges across the country, not least in Derbyshire, with regards to the overall health of the population. And we've certainly been appraised in the previous Joint Up Care Derbyshire infrastructure about the challenges that we have with regards to life expectancy and healthy life expectancy. And certainly that was a founding principle of the journey that's got us to here. Linked to that, of course, we have what I term the care gap. Directly linked, of course, to the health gap and other things, is that we have a challenge around the demands for health and social care in our system. It's no surprise to colleagues that we have a significant waiting list position, certainly worsened and challenged by the pandemic, which we are working hard to recover. But there is what I call care gap in terms of being able to meet all of the demands and expectations on the service. And then lastly, just to remind colleagues that I talk about the resource gap that we have. In other words, the ability for us to respond as a health and care service to points 1 and 2 from the perspective of the people that we have, the financial resource that we have, and the buildings that we work from. And so those, to me, remain our strategic challenge. And as we sort of build the thoughts around the ICB, those are the things that we want to work on. What I think I wanted just to set out very, very briefly, and again, we will come back to this in due course, but if I just set some markers for themes of our conversation, is to say that some of the challenges are the same, but what's the difference? And given the agenda today, for many will seem very procedural, necessarily procedural, I would say, because of the policies and procedures that we need to go through in the inaugural meeting. I thought it'd be useful though, just before we did that, just to set out some of the point of this change and just reaffirm something that John was saying. So if those are our strategic challenges and these remain our operational challenges, my next slide talks about, well, how might we just approach things differently? How might we use the essence of the legislation that's just been passed and come into force differently to influence those key challenges? Operationally, these still remain for the NHS key priority areas. So urgent, emergency and critical care, what we call planned care, which is not just urgent and routine operations, it is also care like cancer care, maternity care, diagnostic care, and of course mental health, learning disability and or autism remain our 3 key operational priorities. And in due course you'll see that the system is geared towards focusing on those priority areas in the way that we do business. But there are 3 new things that I believe mark this change differently and really allow us to, from different perspectives, start to really work together on those key challenges. And they're in no particular order. These are all important. So one change that I believe that we need to really focus on is the integrated, and I use the word strategic really importantly there, about commissioning. You'll see I use strategic in all of these, just to highlight the importance of the work that this board should do. But this concept of getting upstream and thinking about some of the full determinants of health. I'll come back to this in a moment. The second one, which I think is different from where we are and we're making real progress on, that we'll come back to, integrated care. Now that might sound obvious in an integrated care board, but actually I'll talk about in the slide or two's time about the importance of really moving on developing genuine integrated care for those that receive it. And then finally, I think there's a really important part for this board to be overseeing and working with partners to do is this integrated assurance, but a strategic assurance, and working with partners to make sure that we get the right balance in what we do. So those to me feel really important key functions of this board to oversee, not necessarily do, but certainly oversee, support, facilitate, convene where required. And just if I may, a couple of slides into what you'll see come from me quite a lot around why, what is it we're going to do and how are we going to get that done. So very, very quickly, integrated commissioning, this strategic approach. Why? Because we have to take a strategic view of the population health outcomes we want to see, and we have to plan for them. Otherwise, if we don't do that, we risk remaining active, in that reactive space. What we're going to do there, of course, is use the allocation, which is significant, that comes to the NHS for Derby and Derbyshire, and do this balance of the here and now needs in terms of commissioning care requirements against the will and the want that I know this board will have about wanting to be upstream and to think about prevention and getting a balance between the two, because clearly you can't switch from one to the other in one jump. You have to build that into a strategic approach. How we're going to do it is really building on the work we've been doing over the last year or two about what we call our strategic intent. And again, I'll bring back in due course with colleagues the work we're doing in the ICP partnership space around the NHS, social care and public health view of that upstream outcomes focused area of work. And we'll be bringing back to the board lots to consider about the options that we have in that regard. So that's the integrated commissioning. Integrated care. Well, we must do this because, if we look around the evidence across the world, there's much that we can do in the NHS to increase the safety, quality, effectiveness, and importantly, value of care that we deliver to the population. What we're going to do, we're going to bring together those services that are aligned to make sure that our patients don't get caught across organisational barriers, don't get passed from pillar to post, and thinking about pathways of care like urgent care versus geographies of care like our places and our place alliances, and get the right blend of both of those things. Well, how we're going to do it again within the integrated care partnership, the integrated care system, and colleagues on this board know more about this than I do, and but are working on it around the provider collaboration that's going on between organisations and agencies, and this term you'll hear more of around at scale and at place. And I'm sure the board in due course want to hear much more about that and support its development. And then lastly, the strategic assurance role. And really, why? Because it is incumbent on this board to ensure that the health and care services that are commissioned and therefore received in Derby and Derbyshire are safe, are of quality, effective, and again, coming back to this, adding value. And we'll be looking at value in lots of different guises in time to come. What we're going to do, though, we're going to review the outcomes that have been set and those that are delivered against them. And where we can be assured, we'll be assured of that match between the two. But if there are gaps between those, our job will be to make sure that we've got improvement trajectories against them. And I know I've got no doubt we'll take that very, very seriously. How we're going to do it, and this is the key, it's where the integrated word comes back in, because we need to create in this system an integrated approach to strategic assurance. There are things this board will need to do based on its statutory nature, but there'll be things that happen in our provider organisations, and we need to create alignment between the two. We need to create streamlined activity and ways of working that are based on the functions that we need, both in the ICB as the formal commissioner, but also in our integrated care space, and make sure we get the right balance between those and not create unnecessary additional layers, but equally balance that between the need to seek and provide that assurance to members of the public. In all of that, I just wanted to set out, and this applies to all of those key functions. There's some key enablers in there that are universal. There'll be different balances of this between those enablers. But if we think about the importance of information, intelligence, and how we collectively use that, if we think about the approach to transformation, particularly in the integrated care space, the transformation programme that we are wanting to see develop there and is already out and you know, starting to deliver is going to be key. You've seen the importance of partnership. So the word integrated, you know, integration, integrated is filled by partnership. It's not going to happen without partnership, and that applies across. And hopefully you've seen in those, you know, first couple of slides the importance of partnership. Again, communication, engagement, involvement. You know, not just within the NHS and the integrated care partnership, but with our population. We'll have some challenges to work through together, and we need to set off on the right foot around the conversation we have. And of course, this takes a lot of planning. It takes a lot of coordination. And anybody who's just seen the planning round we've been through with NHS England in the previous architecture will understand the importance of really strong planning and coordination across the system. Hopefully today is the inaugural meeting of what is the start of really good governance and leadership across the system, but that is multifactorial, far-reaching, and we'll be building that programme of development to ensure we have that. And then finally, and it's not an exhaustive list, but finally, the importance of research, science, technology, including digital advances, is going to be crucial and will play a part across all of those different aspects. So John, I'm just going to finish there. I hope that was a helpful just introduction. We're going to be building the strategic view at the ICB of these key three functions. We're going to build this conversation, so you know, please don't feel under pressure to respond in the moment, because we'll have lots of opportunity to work this through together. We're going to co-develop this plan that brings about what I call a true integrated care system, and of course we're going to continually test and challenge the improvement. So I'm going to pause there, John. Obviously I will take any questions if there are any from colleagues. I'll just stop presenting that slide.
Thanks, Chris. Are there any comments from anybody? Questions? I can't see any hands, so I'm going to move on. Can I apologise if you couldn't hear my initial comments? I'm not quite sure what the problem was. Anyway, hopefully you can hear me now, and I'll make sure that in the minutes, I'll make sure that they're properly reflected in the minutes of the meeting when those come up, but I do apologise for that early glitch. If I can come back to the outline of the role of the Integrated Care Board, this is really a record of who's going to be chairing the key committees and the other roles that the non-executives will have. So I'm just going to summarise the committee chairs. Dr. Baghdadi is going to be chair of the Quality and Performance Committee. Julian Corner is chair of the Population Health and Strategic Commissioning Committee and also the Public Partnerships Committee. Margaret Gildea is going to be chair of the Remuneration Committee and the People and Culture Committee. Sue Sunderland will be chair of the Audit and Governance Committee, and Richard Wright will be chair of the Finance and Estates Committee, and that will also include the digital agenda in that. You'll see on the paper the other roles that the non-executives have, so just to make sure that those are formally recorded. I don't know if anyone wants to, any questions on those? Thank you very much. We've now got a number of statutory papers and statutory instruments that we have to record. and to consider. So Helen, can I hand over to you for this?
Thank you, Chair, and good morning, everybody. So yes, this next section covers a number of key documentation, key policies, etc. that I'll talk you through. So the first item starts on page 13 of 591, and this agenda item is asking the board to approve 3 key statutory documents. The first one is the Constitution. The second one is the Governance Handbook, and the third one is the Health and Safety Policy. The reason why the 3 of those are grouped together is they're the 3 key statutory documents that we need to formally adopt this morning. So turning firstly to the Constitution. So colleagues, board members will already be aware that we've gone through a fairly detailed, fairly rigorous process to develop the Constitution over a number of months now, which started back at the in August of 2021. We've engaged broadly with colleagues on this call, but also other system partners across Derby and Derbyshire to develop the Constitution for the new Integrated Care Board. And as colleagues will already be aware, the Constitution essentially sets out how the Integrated Care Board will function, how it discharges its statutory duties, how it takes the legislation that's set out, and what the arrangements will be for the new Integrated Care Board to take decisions, how it will be constituted, so on and so forth. So the first document is the Constitution. Accompanying that is the Integrated Care Board Governance Handbook. And this is a series of documents which provides quite a lot more detail on how the governance arrangements within the ICB will operate. It's been developed very much in parallel with the Constitution, and it details the emerging work on the committees that will report to the Integrated Care Board. And colleagues will know that we have 7 of those committees, as just outlined by John, for those key chairing roles. So the Governance Handbook also includes a number of different other important documents. So it covers the terms of reference for each of those 7 committees. It covers the eligible providers of primary medical services, the functions and decisions map, the governance structure, the scheme of reservation and delegation, the standing financial instructions, the corporate governance framework, standards of business conduct policy, and managing conflicts of interest policy. The reason why we have all of that in the handbook as opposed to the main body of the Constitution is we know that as the ICB will mature and develop, there may well be changes to some of the committees, etc. And we want to be able to amend those and reflect those changes rather than constantly having to more formally go through a process to change the Constitution each time. The final document in this section is then the Health and Safety Policy. So obviously, as you'd expect, as a new organisation and as part of the readiness to operate requirements that we've been undertaking for a number of months now, the ICB is required to have a health and safety policy in place as a legal requirement. So again, the third document that accompanies this item is the Health and Safety Policy. I'll pause there, Chair, if that's okay, but formally asking the board this morning to adopt those documents, but happy to take any questions. Thank you.
Should we just go through those one by one? First of all, the Constitution. Any questions, queries on that? I can't see any hands, so I'm going to ask the board if they would approve the Constitution. Okay, thank you. The Governance Handbook. Again, any questions or queries people would want to raise on the Governance Handbook? Richard, can I come to you?
I'm sorry, John, I was just saying, yes, I approve the Constitution.
Oh, sorry, yes, I'd assumed that nobody had
I thought you would want to
so I'd
record
assumed
that.
it had been. Yeah,
I thought
sorry.
you would want to record our approval.
Okay, on the handbook, then I can't see any hands on that. So can I assume that that is approved? I don't see any negative comments coming up. So we'll approve the governance handbook. And on the health and safety policy, any comments or questions on that? Again, I can't see any hands on that, so I'm going to assume, therefore, that people would approve, that we approve as a board the health and safety policy. So just to confirm, that's approval for the Constitution, the Governance Handbook and the Health and Safety Policy. Helen, can I go back to you?
Thank you, Chair. So no further comments from me. That's really helpful. The Constitution, as colleagues may already be aware, has been published. Our new website has gone live. So members of this board, the organisation, the system, and indeed, most importantly, members of our public will be able to view that if they so wish. Thank you.
Thanks. And there's an item here on appointing the ICB founder members of the Integrated Care Partnership.
Yes, indeed. So one of the requirements in the handbook was to set out to list the founding members of the Integrated Care Partnership. Again, they are publicly available and is contained on the new website. So yes, indeed, it's set out there in the paper, Chair, just to be really clear who those members are for the Integrated Care Partnership, or the ICP.
Right. If we can just note those and appoint those, and then make sure that the people there are listed in the minutes for further transparency should people want to see those. Is that okay? Thank you.
Sorry, John, can I just interrupt? It's Darren here. Can I just say to the other interpreter, it's time to swap. I don't think she can see me, so I'm just saying we're ready to swap. Okay.
Okay, that's fine. Thank you. Okay, so the process for approving and developing the essential policy of the Integrated Care Board. Helen, this is you again, I think.
It is indeed. Thank you, Chair. So yes, if I could direct colleagues to page 429. So this paper sets out the process by which we are recommending we undertake to approve and develop the mandatory and essential policies. So as I mentioned earlier, there's been quite a formal transition process that we've undertaken over a number of months now across the system, both in terms of supporting the development of the Integrated Care Board, but also closing down the clinical commissioning group. As part of that transition and transfer and readiness to operate work, we have set out all of the essential policies which the new organisation will be required to have in place. So as part of the work to establish the new organisation, we, as you'll see in the document, we've listed the policies in terms of the different areas. We've also listed the committees that we believe would oversee the development of those new policies, and which committee would be the approving committee, which starts on page 432. We've also listed where they were previously approved, just to give some sense of how new or old some of those policies are, and also the current status for the ICB. So you can see that the corporate team already has a number of the policies already in draft form, ready to start to go through those committees as they start to formally meet now from July onwards. And the programme of work is set out there. One thing to note is where we can and where we should, we will look to consolidate policies. We will look to align them with our system partners, and to highlight, perhaps quite importantly, some of the HR and organisational development policies. That work is already underway across the system, led by Amanda Rawlings, the Chief People Officer for the ICB, in how we can align some of our people policies in line with the One Workforce strategy. So I'll pause there, Chair, if I may. Happy to take any questions, but I'm asking the board this morning to approve the process by which we want to undertake the review of all the policies. Thank you.
Thank you, Helen. Any questions or queries on this? I can't see any hands, so I'm assuming that the board approve this approach in terms of the policies, the essential policies of the ICB. Okay, thank you very much. The Opening Integrated Care Board Assurance Framework and Strategic Risks. Helen again.
Thank you, Chair. So yes, another key documentation, important documentation for the new Integrated Care Board will be, of course, how it manages and identifies and the process in which it will undertake to oversee the strategic risks that it faces. And the board assurance framework is a tool which provides a structure and process that enables the organisation to focus on those strategic risks or principal risks which might compromise the ICB in achieving its objectives. So the paper that you have here, which starts on page 441, sets out a number of things. So firstly, it sets out a suggested opening position that the board may want to adopt, which broadly takes any residual strategic risks that the CCG had at the end of June. In developing the BAF, though, of course, we've looked at a number of other sources as well for the new ICB. So not only have we looked at the CCG strategic risks and the process by which the previous CCG committees underwent to identify those, closing off as many as possible, but recognising that there will be, of course, residual risks transferring into the ICB. Secondly, we've looked at the NHS system partner board assurance framework. So we've reviewed those existing BAFs and we've pulled out where we believe there are common strategic risks that the new ICB board needs to be cited on. We've also noted through our shadow board meetings that we've been having since May, areas where emerging risk has been discussed. And finally, the fourth area that we've looked at to develop this new opening BAF is any residual risks from the transition risk registers. So colleagues will be aware that we've had a system transition assurance committee that helped with the process of transition. So that committee involved a number of colleagues from across the system, and a number of risks as part of the transition were discussed and managed through that. So the paper sets out those four sources of areas that we've used to build the opening board assurance framework. So with all of that in mind, taking those four sources, we believe there are initially 10 strategic risks which are set out in the appendices that the ICB could adopt in its opening position. We recognise, however, that other areas undoubtedly will evolve, and at the bottom of page 442, we've listed some of those areas that we believe we need to pay some attention to, either as strategic risks and/or as part of the operational risk register that we will also have in place. The second part of the paper, therefore, sets out the process by which we want to develop a full board assurance framework. So we recognise that this is a suggested opening position, and we know that further refinement and development will form part of the board development sessions taking place throughout July through to September. The finalised and fully populated board assurance will be presented to the board at its September meeting with the full mitigations, the full risk scoring for each of those strategic areas, and to be refreshed and represented at the board quarterly thereafter. We'll be asking the July and August committees to accept the opening strategic risks that we've outlined in Appendix 2 at their inaugural meetings throughout the summer months, and to be developed and refined in line with the outcomes of the development session, so we can then fully populate the BAF for September. And we've also asked our internal auditors 360 to help facilitate a discussion in the autumn months around risk appetite as part of the ongoing board develop sessions. So I'll pause there, Chair, if I may. Happy to take any questions on that at this point. But the purpose of this paper, as I said, is to ask the board to adopt the opening position, to comment on the process that we're setting out here to undertake the full population and work for the BAF ready for the September meeting. Thank you.
Thanks, Helen. Sue.
Thanks, and thanks, Helen, for all the work that I know you've been doing to pull this together. And thank you for having had sight of this early on and your thoughts about how it's going to develop. I really see this as a starting point, and I welcome the opportunity in the development sessions to take this forward and think about how it reflects our priorities and risks going forward. So it's really just to endorse the way that you've set out and recognise that there is quite a lot of work to do, but it's an evolving picture and it gives us a safe place to start from and to build on as we go forward. That was all I wanted to say. Thanks.
Thank you.
Yeah, thank you, Chair, and thanks, Helen and Sue. I just thought I'd use the opportunity, just again in the inaugural meeting, just to pull out as we develop some of the key differences in the creation of this. So absolutely, Helen, in my view, is completely correct about the start point. How do we build something from previous and work from there, but obviously develop in due course. There's a really subtle difference, I think, in this architecture now from what's gone before, about the two key roles that the ICB needs to play. So in my view, you've got the ICB as an organisation with its statutory duties, and therefore in the board assurance framework and the various risk registers we'll have, there's that lens about risks to the organisational statutory duties. And then you've got this broader duty of the Integrated Care Board around the facilitation of the partnership and the system. And in that language, we've got the risks that are in the broader NHS family that we need to consider, including our partner organisations, our foundation trusts and others. And you've got the risks that are in the even broader integrated care partnership with our colleagues in local authorities to consider. And so when we create the board assurance framework, we need those two things in mind, and they both have to be there. So the risks and the framework as per the organisation, and the broader risks as part of a convener of the system. And I think it's really important. They shouldn't be necessarily different, but the slants you sometimes take is different. They should be aligned. There shouldn't be a misalignment of those as we work through, but a slightly different view on them. So I hope that's helpful and look forward to shaping it. Really interesting conversation already in our subcommittees in shadow form about what are the risks that they hold and they manage and monitor, and how do they all then come together at the board level so that we triangulate and get that holistic view. Already important conversation in the finance one about the interconnectivity of the risks and the importance of this board taking that view and doing the balancing act across the risks. Thank you, Chair, and thanks, Helen, and thanks, Sue.
Thank you. I can't see any other comments, but I'd just like to reiterate both Helen and Chris's comments and Sue's as well. This is the start. I think this is one of the areas where, as we develop our partnerships, as we develop the system working, this is one of the areas about how we identify and manage risk that we are going to have to do quite differently into the future. And I think that was brought out very much. So just asking people then, as I can see no other hands, that people are happy to approve this. Thank you very much. And Helen, again, the opening Integrated Care Board Risk Register.
Thank you, Chair. So yes, this paper starts on page 448. And this paper really supports and further accompanies the previous discussion on risk. But this is the suggested operational risk register that covers a number of areas across across the organisation. So the ICB Risk Register is meant to be a live management document which enables the organisation to understand its comprehensive risk profile, so not just the strategic risks but also those more operational day-to-day risks as well. What we're proposing through the committee architecture and infrastructure, that the risks appended to this paper are allocated to the numerous and relevant committees who will, as we would expect, systematically review these existing risks, but also identify any new ones each month and agree and discuss the latest position on them, any mitigations, any controls, etc., that we can then more actively manage as the organisation develops. I don't intend to go through this in any particular detail, Chair. I'll certainly take the paper as read. Obviously, colleagues can see there's quite a lot of detail to it, to the register itself. But just to provide assurance, I suppose, that again that the sources that we've used to develop this risk register has been from numerous sources as part of the formal close down of the CCG, but also as part of the transition arrangements and the establishment of the new ICB. So the paper in the summary section on page 449 just lists those source areas. So the previous CCG governing body position, the system operational resilience group risks, where they need to be recorded, the risks from the transition arrangements, including the system transition as well as the CCG transition, but also, and importantly, the risks as part of the gloss up transition. They've also been encompassed in this report. So in terms of recommendations and next steps, asking the board to note the opening risk position transferred to the ICB in this paper. Again, we'll be asking the July and August ICB committees to accept the opening risk position at their inaugural meetings, and further discussion to take place on the ongoing development of the system governance around risks, but also recognising we've got other parts of our system that are really key and important to the delivery of the objectives across the system, including, of course, the delivery boards as an example. So I'll pause there, but happy to take any further comments or questions. Thank you.
Any comments or questions on this? Okay, thank you very much then. Thank you, Alan, for that. Keith, the process for appointing the external auditors.
Thank you, Chair. Good morning again, everybody. Just a short paper commencing on page 457, which I'm hoping is self-explanatory. But just briefly by way of background, normally any contract that the CCG had in place would automatically novate to the ICB. That cannot happen for external audits given their independence. So the paper is saying that we need to have a review of the specification of the external audit contract that existed for the CCGs, and check whether or not it's fit for purpose for the role of the ICB, and to come back to the board at the next meeting with a recommendation as to whether we do novate or whether we go back to market. So to do that independently and objectively, it needs a small group of people just to come together and look at the specification that currently exists. So I'd suggest working with the Audit and Assurance Committee Chair to get a small group of people together to do exactly that, and then bring a recommendation back next time we meet to the full board. So the paper is asking for that process to be adopted by the board. Thank you.
Thank you, Keith. Sue.
Just to say, we've got a panel date planned in after the next audit committee, Keith. So yeah, it fits, just as you're aware.
Thank you for that. Appreciate it. Thanks.
Okay. Any questions on the arrangements for appointing the external auditors? Thank you.
Thank you.
Helen, the closing due diligence checklist for the Derby and Derbyshire CCG.
Thank you, Chair. So yes, this is for information and for completeness, really. So this paper starts at page 463, and it includes 4 key documents that formed part of the closure of the CCG and formed part of the transfer order to create the Integrated Care Board. So you have the Derby and Derbyshire CCG closure report, the boundary change report, the changes to the due diligence checklist, and the letter from the CCG accountable officer. So the board is asked to note the contents of this report for assurance and information, and no further comments from me, Chair, unless there are comments or questions from board members.
Any comments or questions? Thank you. Thanks, Helen. Zara, the delegation of services from NHS England to ICBs.
Thanks, Chair. So from page 477, this item is for information. We have previously governed it with delegated authority to our Chief Exec to sign the agreement, but I think it's just really important to share here and just pull out a few of the key points. So this is the delegation agreement for the transfer of responsibilities for primary medical services from today from NHS England to the ICB, but also for further services for the full breadth of primary care, so also covering pharmacy, optometry and dental from April of next year. There is a sort of a raft of activity currently going on between ourselves and NHSE just to do some more work with a view that in mid-September we will be formally applying to take on that sort of broader breadth of services from next year. A couple of areas just to pull out. So we are still through those activities understanding the workforce model. So in terms of workforce that is currently assigned to NHS England, how that workforce will support the resourcing required at local ICB levels. And also from a finance perspective, we are still working through with NHS England in terms of the financial position and what we will be inheriting as we go forward from here next year. So clearly we will bring updates through the board as those things develop further, and certainly be bringing through in advance of September the application that we will wish to submit. Very happy to take any questions, and as I say, there'll be more updates on this really important work in due course.
Chris.
Thank you, Chair, and thank you, Zara, for bringing this to board's attention. If I could just say a few words and connecting this to my opening statement, really. So if I take us back to the why, the what, and the how of this. So to draw out why is this paper, although it's for information, so important? So as part of the Health and Care Bill, government and therefore NHS England is signalling the intent to bring the view of total resource allocation together. And that's a really important position. So in the previous construct of the NHS, we had commissioning responsibilities between local CCGs and NHS England. And what this is now signalling over the next couple of years is the direction of travel of bringing that total view back together. So that's the why, so that we can really think about the spectrum from highly complex, highly specialised care that we need to commission to care much closer to home and the preventative end of the spectrum. We start to see that continuum. So that's the why of it. The what is what Zara is starting to talk through about the different types of commission that we will need to have a greater ownership and leadership over from where CCGs used to have. So from today, full delegation of the primary medical services and to put that in different contexts, general practice is what we're describing there. And as we work between now and September, really thinking through the broader primary care areas such as pharmacy, dentistry, optometry, and so on, but also starting to think through specialised commissioning. So those are the what's there. The how is as I described earlier. So I mentioned the integrated commissioning and that strategic. This is a core element of that integrated commissioning work, not just through the ICB, but creating a really strong connection with NHS England colleagues who will retain some responsibilities and accountabilities, but really building that partnership, but also starting to think about our work with local authorities strategically as we consider health protection, vaccinations, and so on. That this will form a really important part of that integrated commissioning work. And then lastly, in the how, it's not just about Derbyshire. So we are forging really strong links across the East Midlands and the broader Midlands about some of these. How do we do them together? So getting the balance between delegations coming back to local areas from NHS England, but then how you deliver that, probably in partnership across the East Midlands, across the Midlands, because some of those services are of a scale that actually it wouldn't be sensible to disaggregate them completely, but the input into them really important. So having that local influence over something that you operate at a greater scale on, I think is going to be crucial. So John, I hope that's helpful context in the sort of why, how, why, what and how, and really important updates will come to board for board's view in the months to come. Thank you.
Thank you. Buck, you had your hand up. Did you want to add anything?
No, Chair. I think Chris has just cleared up a couple of points I had. I think it was particularly around the working across regionally on some of these, and I think Chris already mentioned that, so nothing else from me.
Okay, thanks. And just to draw attention to the welcoming of that, the approach that Chris has just been saying, noted in the chat box. So thank you for that. Thank you, Sarah. I mean, I think what you've heard from Sarah, but also from Chris, is this is going to be a developing agenda for the board. And we'll have to reflect and make sure we create time to really understand how this works in a different way, and how we do get this bringing together, and some of the potential benefits that we'll get from that. So this will be an important part of the board's work. Thank you. And the Transition Assurance Committee, final report and minutes. Before Helen talks to this, can I just thank this committee for the work they've done over the last year. They've been the Assurance Committee we've looked to advise the Shadow Board about progress we're making on getting to where we've got to today. Dr. Bhatia chaired this committee, but it's done some really good work, and I'd just like to put on record my thanks to Dr. Bhatia and the other colleagues, members of this, for the huge amount of work they've done in overseeing overseeing safely the transition from the CCG, and indeed the introduction of the Act to where we are today. So thank you very much. Helen.
Thank you, Chair. So yes, this report starts on page 579, and it sets out, it includes, the final set of minutes from the Transition Assurance Committee, which met for the last time on the 9th of June, and also the assurance report, and colleagues will see, get a sense from both the minutes and the report, the type of discussion, the work, the support and expertise, as you've just outlined, John, that the committee has provided during the last 13 months or so to support the work of the transition. So no further comments from me. It's here for completeness and final assurance. Thank you.
Thank you very much. Any questions or comments on? Okay, thank you.
Thank you.
And the final item is the forward plan, and we will be developing